And thank you, ACOI, for hosting this. And just a little background, like she said, my name is Vic Gongedy. I'm a cardiologist, a practicing cardiologist since 2012 here in Florida. And I went to school in California. Toro University is my DO school. So let's get started. Just as a little basics to begin with, this is going to be a topic about basic EKG readings. So I just want to have an understand of you guys to have an understanding of what the fundamentals of EKGs are. And this is by no means an advanced EKG talk. So there's a lot of detail, nuances about, Brugada or other kind of stuff that I am not going to get into during this talk, just because it's a big topic. Just as a reference, when I was training as a cardiology fellow, we would have EKG talks once a week, every Friday mornings, and this is for 3 years. So it takes time to get proficient at EKG readings, and the best thing is keep reading. Just constant use. I'm going to start off with a little bit of background, just so people understand what the intrinsic physiology is and and this kind of helps figure out why the electricity works the way it does. So it's always helpful to understand that the SA node is our intrinsic pacemaker. That's what I always tell my patients. And from there are certain branches or wires that go down to what I call a central substation, or in this case, the AV node. And from the central substation, there's three electrical wires that distribute out. That's the left bundle, the right bundle, and from the left, there's a second one, the left anterior fascicular block. And so that's the conduction I want you guys to understand and be able to explain to patients. So, one of the key things with anything we do in medicine, not be it EKGs, be it with evaluating patients for heart failure, MI, I'm biased because I'm a cardiologist, but anything you pick, whatever you do through your medical career and onwards, just set a pattern and just follow that pattern, develop it, and you do it systematically every single time, exactly the same way, because then you won't forget. If you're jumping around, that's how you tend to miss a lot of things. So I always tell my medical students just whatever pattern you were taught in medical school or whatever you're comfortable with, stick with it. I'm going to tell you what my pattern is, and this is what I teach my medical students and my rotating residents and my nurse practitioners. So this is the pattern I've learned, and this is what I pass on. So the first thing first, when you're reading an EKG, make sure it's the right patient, and also make sure it's the right date. It's the basics. It sounds silly, but you won't believe how many times the wrong EKG gets into the chart, and all of a sudden the nurse is calling you or the resident is calling you, freaking out that there's been a change in the EKG, and consulting cardiology, when all they had to do was read when the patient got transferred from the ER to the floor, the wrong EKG got scanned. By the time it gets into medical records, it may not be there. So sometimes you're relying on paper records. So always verify that it's the right patient and the right date. I think it's less and less happening nowadays because most EKGs are directly in the EMRs immediately. But in case it doesn't, I just want you guys to be aware that checking the right patient, the right date, the right demographics is the very first thing you should do when you're reading an EKG. Now, the other thing is verifying the speed of the EKG. I'll get to this later on, but I just want you to understand that there's a standard speed, and usually it's 25 millimeters, seconds. So milliseconds, sorry. So the standard speed is 25. So if it's faster or slower, you got to be aware if somebody changed the settings on the EKG machine. And after that, set up a pattern. My usual thing is rate, rhythm, axis. That's what we've learned. And when I talk about rate and rhythm, it's the basic things. First thing, is it fast? Is it slow? Rhythm, we'll talk about, is it regular? Is it not regular? And then you start off reading as with writing, right to left. So here's again the speed, the standard speed on most EKGs is usually 25 millimeters per second, and the standard height. If you guys can't use my cursor, but you see where it says 10 millimeters or 1 volt, that's the standard. Sometimes, and it's two boxes because sometimes it could also refer to the chest leads and the limb leads. So if you see a step up, that means they use two different voltages. So something to be aware of is check the basics like the speed. Is it the standard speed, which is 25? And is it the standard volts, which is 10? And is it for both the chest and the limb leads? And then understanding what each box means in terms of the timing and milliseconds. So one small box is 40 milliseconds. So five of them together is 200 milliseconds. So that's a big factor. So people always, some of the medical students say it's four boxes or five boxes. I say, well, that's great, but what is it in milliseconds? Because we think of the heart in beats per minute, and it's in time, not just boxes. So something to be aware of. So learn your boxes, and it's pretty easy. And okay, once you identify that the basics are correct, it's not that it's incorrect, but you just need to know that this is the standard, and if it's deviating from that, you got to readjust your QT evaluations and the PR evaluations and everything else. So something to be aware of. And then once you start reading it, again, I always start with right to left. So start with the very first thing that's happening, which is the P wave. That's where the atria is depolarizing. And then it goes to the AV node, and that's interpreted on the EKG as the PR interval. And that's where the signals from the SA node and they come into the AV node. And the AV node is like the spiral that slows down the conduction. And so that's why you get the AV delays. And from there, it goes down the his bundle and to the Purkinje. So and the QRS complex develops and the ventricle starts to depolarize. And after depolarization, as we remember, there's isoelectric point and then repolarization. And that's what the ST segments and the T waves represent. So learning the what are the normal patterns, normal EKG intervals. So this is something that you just have to commit to memory. A normal PR interval is less than 200 milliseconds. So it's about an average is between three boxes, which is 120 to 200 milliseconds. Why is this important? Again, you can get prolongation of the PR interval, and that's the AV blocks like first degree or second degree. Or you could even have, in certain cases, short PR intervals. And so those can cause pre-excitation. So this is why it's important to evaluate the PR interval. And the normal PR interval is at least three boxes, so which is 120 milliseconds, or 200 milliseconds is the average. Anything more than 200 is considered a block. The QRS, again, is less than 120 milliseconds is the normal. Anything more than that is considered a bundle branch block of sorts. And then finally, the QT interval. And this is important when you're adjusting medications, other interactions with therapy, starting antiarrhythmics. So you need to know what the QT intervals are, and the on average, it depends from male and female. It's anywhere from 440 to 460. So I always use 450 as the average for pretty much everybody. The red flags for a QT prolongation is if you start to see anything above 475 and definitely above 500. That's something to be aware of. So again, a normal QT is around 450. And then calculating the heart rate. Again, and there's different ways of doing this. The one I usually say is just remember that, the 300, 150, 175 rule. And basically, you're dividing 300 by the RR interval, or the big large squares, to get the overall heart rate. Another way, if it's very slow, like in a bradycardic patient, is you count the number of heart rates in a 10-second sheet, because each sheet is about 6 seconds, and so you count how many beats there are and multiply that by 10. So if you count four heartbeats in one EKG sheet, which represents 6 seconds, that's 60 seconds, 60 beats per minute. After you calculate the heart rate, so again, when I first look at it, I say, well, let me go back. Is this going fast? Is this going slow? And visually speaking, is this more than three boxes, or is this less than five? And so if it is less than five, that's where I use the 6 second rule. Otherwise, you just have to be aware of how to calculate it. And then after this, trying to figure out the velocity or the vectors of the EKG. And this is where axis determination comes in, because this will help determine if the patient has a bundle branch block, right versus left. So a normal axis is when both leads in lead one and AVF are upright. So it's that whole idea of, well, I teach the med students and nurse and my NPs that it's the thumbs up rule. If both one and AVF are up, then that's a normal axis. If one is up and AVF is down, that's a left axis. And if one is down and AVF is up, that's a right axis. And all of this, there's a really good website you guys can go to. I'll talk about it at the end. There's actually two of them, which have good information. So again, starting after you determine the rate and trying to figure out the axis, is the rhythm regular? Does it seem erratic, or does it seem like it has a metronome that's very steady? Is there a P wave before every QRS? Is the QRS narrow or is it wide? And that's how you determine if it's what kind of rhythms they are. So, for example, here's a strip. Again, you're starting from the basics. You look at the speed, and I think my pictures covering it up. But you see that every QRS has a small little P wave. So, and it's very regular. The spacing between the RR interval is very regular. So this is a sinus rhythm. Here's an example of where the RR intervals, there's no regularity to it. Some are slow, some are fast. And then when you look a bit more closely, you can't find any P waves that are associated with each QRS. You see P waves like in V1, which is a good lead to look for P waves. You see some P waves, but they're not necessarily associated with a QRS complex. So this is an example of atrial fibrillation. And I want to okay. So again, if you look to the left of the picture, you see the what looks like a tombstone. So that's what I mean by the voltage. Those by standard are set to 2 boxes or 10. And in this case, it's both of them. So the limb leads and the chest leads are at standard level. Here's another one where again you see it's going fast because it's about 2 boxes or less than 3 boxes. So that it's more than 100 beats per minute. And so it's fast. But it's regular. It's unlike the last one. This is very regular. But when I'm looking closely, I don't see a discernible P wave. And so this is what we called an SVT. And again, so an SVT is it's actually an umbrella term. It's a bucket term for seven different types of arrhythmias. They include sinus tachycardia, AFib, A-flutter, AVRT, AVNRT. So again, that's in a more advanced EKG talk. But again, this you can tell is not a normal EKG because it's going fast and you cannot see a discernible P wave. So you can blanket statement as a SVT. And, when you're on your cardiology rotation, we can go into details on how to figure this out as to which type of SVT it might be. And here's another interesting one. So if you see this, you have to worry because this is not a good rhythm. As you can see, first of all, it's wide. And it's more than three boxes, and it's very irregular, and there's no pattern. This is VT, so ventricular tachycardia. So once you figure out if it's a regular rhythm, if it's or not a regular rhythm, we go back to reading it from left to right. So the very first thing is the P wave. We try to find if there's a P wave or not. After the P wave comes the PR interval. And this is the AV delay we were talking about earlier. The normal is again 200 milliseconds. So it's between 120 to 200 milliseconds. And anything more than 200 milliseconds is called first degree AV block. And so that's the first type of AV block. Now there are three other types, which is the second degree, and second degree is broken down into type 1 and type 2. And with second degree, the PR interval prolongs. So it increases with every beat, and all of a sudden there's a P with no QRS. So it's a dropped beat. That's how you know it's a second degree type 1. So it's a prolongation of the PR. Another type of second degree is where the PR interval is constant, but you have a dropped P. And in some cases, it becomes hard where there's no the PR interval is fine, but then there's all these dropped QRS, and that's of course a third degree. And sometimes when you go back and look, the P's don't necessarily march with the QRS complex, and that's a third degree. This can be tricky, especially if they have what we call a very high grade type 2, which is leading into a type 3, and that gets into semantics between some people. Is it a type 2 or a type 3? It doesn't matter at the end of the day if it's symptomatic. A type 2 will still get a pacemaker. And so if you see a type 2 or if you're suspecting a type 2, be very cautious and because the patient may end up needing a pacemaker. The type 1 second degrees can be monitored and not necessarily lethal in that sense. Now, the QRS complex. So the QRS complex, again, is representing the ventricular depolarization. The normal is around 120 milliseconds or three small boxes. Anything more than that is considered a bundle branch block. So that we have two different types. Again, remember we had the signal coming from the SA node into the AV node, and then going down the bundle of His and spreading into the right and left branches. So if there's a block on the right side, this is the pattern you get, which is a QRS greater than 120 milliseconds. And then usually in V1 and V2, you have a RSR pattern or this M pattern. Some people call it, the bunny ears. That's the RSR prime. Sometimes you may not see that. You may only see like a slurred S wave on the leads of V6 or A1. And again, that can also be a right bundle branch block. So that's something to remember. Again, it's greater than 120 milliseconds with the typical RSR pattern. And if you have the RSR pattern without the full 120 milliseconds, some people call that incomplete right bundle branch block. Likewise, there is a left bundle branch block. Again, the QRS has to be greater than 120 milliseconds. You look at V1, and if it's completely down, that's one of the criteria for a left bundle branch block. Or if they have a very broad or tall R wave in V5 and V6, that's another criteria for left bundle branch block. Sometimes, if you do not see a Q wave in the lateral leads at all, that's a sign pointing towards a left bundle branch block. And there's other criteria in terms of prolonged the start of the R wave measurements, but that's a bit more detailed. So just remember, if the QRS is greater than 120 milliseconds, you have a very dominant S wave or a downward slope in V1, or a very tall R wave without an S in V5 and V6. That's left bundle branch block. After you have the bundle branch blocks, then you have, after the QRS, you have ST segment. So the ST segment is the isoelectric point. And so, ST elevation is indicative or suggestive of an acute injury going on. ST depression or a T wave inversion can be a sign of ischemia, something to worry about. And usually it comes with reciprocal changes. So here's an example of an ST elevation. So when you're looking at an EKG, the ST elevation is based on either the TP segment, meaning the isoelectric point between the end of the last T wave and the P wave. That's the TP segment. But most people use the PR interval as the baseline, something to be aware of. And so if it's above more than two boxes, that's a sign of an ST elevation. So and then you can have what looks like an ST elevation, but it actually turns out to be more of a PR depression. So this is why when you look at in this segment, it looks like there's ST elevations all throughout, leads 2, 3, AVF 5, and 6. And so when you're seeing stuff like that, it doesn't follow any kind of coronary pattern. It's diffuse, so you got to suspect pericarditis, but it's actually not an ST elevation, and it's a PR depression. So the isoelectric point is the TP segment, and the PR is actually below that, so it makes the ST segment look like it's elevated. In certain cases, you have early repolarization. So either very like an athletic heart or hypertrophy, ventricular hypertrophy can create these early repolarizations. And so they have a slightly different upswing to their ST elevation from their baseline. Once you look at well, let's talk a little bit more about the ST depression. So here's some few examples of ST depressions and T wave inversions. As you see in leads V2, V3 through 6, you see clearly that the ST is depressed more than 2 millimeters. And again, this is indicative of ischemia. Here's an example of an EKG that shows the ST segments are fine, but the T waves are inverted. And again, this is suggestive of ischemia as well. So something to do, because a normal T wave is an upright T wave. Let me just go back. I'll stop here for now and open the floors up for questions. So again, the basic thing is going back and remembering that set a pattern to however you read it and follow that pattern. Start with the basic demographics and follow through on your right to left pattern. I do want to share, let me see if I can find this. There's a really good website, one of which was in my talk earlier. Yes, here's the website. It's the litfl.com. They have a really good EKG course on there if you guys want to go in and take a look. And then the other one is done by one of my mentors during fellowship. His website is ecgedu.com. Again, ecgedu.com, and that's Dr. Scott Siegel, who developed that website. And it's actually a very good website for medical students, residents. I have, whenever people come on my rotations, I have them go to that website. He has a good tutorial on how to read the EKGs, and if you want challenging cases, you can see some of those cases as well. And there's some examinations and tests you can take to see how good your EKG skills are. But the basic thing is with EKGs, you just keep reading and get better at it.
We do have a question in the chat. First question, we actually have a couple now. When you first look at an EKG, which leads should we look at first after looking at rhythm and rate?
So I look at all of them. The best lead for identifying the P wave is V1 or the inferior leads, like lead 2. So if that's how, but does that make sense? I'm not sure if so if you're trying to read from right to left, you're trying to identify a P wave. V1 is the one that's the closest to it. V1 and V2, remember, are the closest to the H'er. They're at the top, and that's how you can easily identify a P wave, and it's usually upright. In sorry, it's down in V1, and sometimes it'll be upright in V2, and in the inferior leads, it should be upright. And lead 2 is usually one of the best ones to identify P wave.
Here we have another question. How comfortable with the basics should we be before we get into more of the nuances of reading different ECGs for rotations and going into residency?
I think you got to read at least 50 to 100 EKGs before trying to get into complicated ones. I mean, it's because by the time you got to know your basics before you can try to figure out, because you have to know what's normal before you can figure out something doesn't look right. And you have to, and it's all about pattern recognition. So, because, you may see attendings on your rotations, they're given an EKG and they're like, okay, it looks fine. And you're like, how did you read so quickly? It's because it's pattern recognition. You look at it, and this is what I say. This is this fast? Is it slow? Is it regular? Is it not? And this is something that happens because we've read so many of them and we just know this looks fine. Or this is, oh shit, this is something serious. I got to take care of it. Like that VT, like, that's not normal.
Okay, and then we have one that says, can you please go over again how to differentiate or approach PR depression versus ST elevation in the pericarditis example?
Yeah, let me go back. I wish I had a pointer, but okay. So, everybody for some reason thinks that the baseline of an EKG is the PR interval. It actually isn't. The most isoelectric point is the TP segment. That's when there's no electric activity going on, and that's why it's isoelectric. The signals are equally balanced. So the TP segment is the baseline. And so the PR interval is supposed to be around the same level as the TP segment. So if you see that the PR interval is depressed, you got to think. Let me restate that. Sorry. If you see that the ST elevation is the ST segment looks elevated, stop and step back and look at the PR interval. If the PR interval is less than the TP segment, the one of the QRS complex from before, you know that, well, maybe this is pericarditis and not actually an ST elevation. So again, because the first thing you're going to see when you see this EKG is, oh, this could be an inferior ST-MI. Is it or is it not? And then you said, well, let me step back and make sure it's not pericarditis, because then you look at the TP segment and you realize that the TP segment and the ST elevation, what is the ST elevation, is actually at the same level, and it's the PR depression is what's actually going on, and that's how you know this is more of a pericarditis. And of course, clinical history. Don't forget clinical history.
Any other questions? Feel free to put them in the chat, or you can unmute and ask out loud.
Again, I strongly urge you guys to start with the basics of this, but read as many as you can and use resources. I mean, there are many resources online now, like that one website I told you about, as well as the ecgedu.com. That's another really good website.
Okay, we got another question that came in. What do you look for when identifying repolarization changes, such as in hypertrophic cardiomyopathy?
So typically they're not as symmetric, and you'll see them in multiple leads, not just if it's an ischemic related issue, it would usually be in coronary distribution. So in this situation, it's mostly the V2, V3, and V4. Whereas if it's hypertrophic, it would be pretty much in all the leads.
Not seeing any other questions. All right. Well, thank you, Dr. Gongidi, for your very thorough basic overview of EKG interpretation. I want to thank everyone for joining us tonight. If we will be making this, we did record the session. We'll be making it available for reviewing via YouTube in the next coming days. So keep an eye out for it if you want to review any of the information or pass it on to your friends. I hope you all have a great evening and a great Thanksgiving. And we will be having some additional student lecture series. December's will be pre-recorded. It'll be released about mid-December. It'll be about how to present a case and how to present a poster. And then we'll have some live ones again starting at the start of the new year. So have a good evening and thanks again.
Thank you.